The most common reason for a woman to transfer into a hospital is either because she wants pain relief or because her labor isn't progressing. So Pitocin or an epidural, and those are both within your independent scope of practice according to California law.
Yeah.
So hospitals can better integrate midwifery care by allowing community midwives to transfer to hospital midwives when those things need to happen, so that the patient continues to get really trauma-informed, person-centered, gentle care.
Welcome back to The Bleeding Truth. My name is Sally McNally. I'm the Irish midwife.
And I'm Brigid, Sally's daughter.
Today we are happy to start season 2, and we're starting with a very special guest, my very good friend, Paris Maloof-Bury. Paris is the president of the California Nurse-Midwives Association. She's also the associate editor of Healthy Mom and Baby magazine. Paris has a lot to share about women's health and anything to do with women. We want to hear from Paris, especially about her ideas on politics and policies and the culture that we live in today.
Thank you so much for having me. It is really fun to get to see you both in this format. I've been a fan of Sally's since I was pregnant with my first baby.
Oh,
it's true.
Yeah, so thank you. And I remember meeting you when I was younger too. It's been, so wonderful to have you part of our friend group and everything for so long.
Yeah, I feel incredibly lucky that way.
Could you tell us a little bit more about yourself and how you maybe got into this realm of midwifery and everything, and all the way, to your position now as president of the California Nurse-Midwives Association?
Sure. Well, so currently I work as a midwife in Davis in California. I live in Sacramento, so it's about a half hour. I provide full scope reproductive healthcare services, prenatal, birth, postpartum, lactation, mental health, well person, family planning, including abortion care. And I also am incredibly fortunate in that I am at the Capitol. So I have lots of opportunities to satisfy my passions for advocacy. But I got into midwifery when I was a very young person. I was living on my own without a roommate or partner for the first time. I think I was about 24. And I had, up until then, I'd been really interested in pursuing a career in music and was belly dancing professionally. And, I loved writing songs and dancing. But I was going through this period of reading novels that were re-envisionings of stories that had been originally told from a men's perspective. So, the Myths of AWHONN and The Red Tent and those types. And I said to one of my friends, I was like, wow, I really want to be a midwife. I want to be this wise woman that helps other women along their journey in these marginalized spaces. I wish I could do that. And she's like, oh, you should do it. And I was like, well, I should do it. How do you do that? And she's like, just go to school. And I was like, oh, well, that's brilliant. And so that's what I did. I started looking into what would give me the greatest access to care for the most women. And at that time, it looked like nurse midwifery was the route to go. And so I started my prerequisites and got into a nursing program. And truth be told, during my OB rotation in labor and delivery, I was really turned off, actually, by what I saw. I saw what, from my perspective, seemed abusive, if I'm being honest. And like many aspiring midwives, I was kind of stopped at that point and was kind of captured by nursing instead. And instead of doing my clinical preceptorship in maternity care, I stayed in cardiac. I was in a progressive care unit where I was hired into telemetry, and then I was in a training program to join the intensive care unit, which I loved. I loved codes. I loved all the cardiac stuff. And during that time, I was pregnant with my first baby. And naturally, being that I had an affinity for midwifery, I chose a midwife. I did not choose a hospital birth because, well, my mother had me at home, but also because I was very disturbed by what I had seen. And it might have been that that wasn't their routine. It might have been that I just happened to see one bad experience. Who knows? So I opted for a home birth. And in my community, the only midwives who provided home birth were CPMs, certified professional midwives, not nurse midwives, which was not the route I planned on taking for myself. And I remember one of my coworkers, another nurse, she's like, well, why do you care if she's a nurse or not? She's excellent. It was the same midwife that she'd used. And I will call her out, Sue Turner. Yay, Sue. I love you, Sue. She saved my life. And she literally did save my life. So at home, I had a pretty rough birth experience. I had a postpartum hemorrhage. The estimated blood loss on my records was 1,800 cc's. Yeah. And yeah,
I remember your story. Yeah.
and
Yeah.
she wanted to transfer me to the hospital. She's like, okay, we're going to call 911. And I said, no, I'm not going because I was afraid they would treat me bad and shame me for choosing not to be in the hospital.
Oh, wow.
And take my baby away from me, and not take the baby, but like put the baby in the nursery, or that I couldn't have my baby with me. I just was sure that they would be looking down on me for having made this choice. And so I told her no. And Sue was like, okay, well, if you faint again, if you become unconscious again, we will transfer you then, like letting me know that they weren't going to wait for me to die. And so, I just kind of sat there with my eyes peeled open while they were getting IVs going, and oxygen and Pitocin and a catheter, all the medical interventions at home. But she kept me alive. She did a really good job. And then naturally, I had a beautiful run-in with postpartum depression. And in all of that vulnerable susceptibility over the months, I remember her saying, you should, I guess it was over weeks because I was still on maternity leave. She said, she encouraged me to transfer to labor and delivery and to pursue my career as a midwife. That had been my dream. And she's like, people shouldn't be afraid to go to the hospital. You could make a difference there. That's my husband. He's my papadural.
Hi, Lance.
I didn't have an epidural. I had a papadural. But she kind of, challenged me to make it safe for people like me to go to the hospital if they needed to, and to provide trauma-informed, gentle care. And so I did. And it was hard, for sure. It was, there was a lot of, let's say, abrasiveness between me and that system for the first few years. It was
You reminded me of a really hard yoga pose. It's good for you, but it's so hard. It's so hard.
It was really
and
hard.
you rubbed everybody and made everyone think and made us change our policies and work harder for women, basically. And you brought it, Paris. You brought it, and I really learned so much from you, and I'm still learning so much from you.
Oh, my Sally.
And we're still using, the stuff that we all started when you were with us. We should probably update it a bit, but some of it's still really good.
Oh, I feel so much gratitude for, I know that it wasn't necessarily a welcome thing to have me there. People don't like to be faced with change agents. And so I feel grateful that I was allowed to be there. And I did so much learning. I learned about advocacy for both nurses and for people, for our pregnant mothers. During that time, I became a childbirth educator. Sally and I started the natural childbirth classes together for the first time, which was really fun. And I became a board certified lactation consultant, and I started running support groups for mothers, not just at our hospital, but from mothers from the community as well. I felt like that was the training ground for me to really get on my clear on my values of what was important to me. And I spent a couple of years working in the NICU as a lactation consultant, not as a baby nurse. So like kind of midwifing moms and helping them to attain their maternal role in a very medical setting. And during that time, I had another baby. And I did not hemorrhage. Ooh, and that was exciting. My first baby was about 10 pounds. He was 914. And my second baby was a great practice in humility for me. When I declined, I was a very bad patient. I refused to do the 3-hour glucose tolerance test when I failed the 1 hour. And instead I said, I want to get a diagnosis, just get me in with an endocrinologist. And I ended up on insulin and receiving all kinds of really helpful medical care. And my baby was 8 pounds, 5 ounces instead. And I did not hemorrhage. It was beautiful. Didn't make it to the hospital in time. But that's another story. And so when Xander was a little bit older, I went back to school and studied to become a midwife. Gosh, here I am. It's been really,
and isn't
really
it wonderful that all those years ago, your friend said, you should do it. You said, I would like to be a midwife. And she said, do it. And that's what I love about America, that whatever you can dream about, you can do it. You can just
Isn't that
go
crazy?
and do it. Yeah, it's so wonderful, because I remember when we were working together way back in labour and delivery as RNs, and sometimes we'd be together scheming and planning and talking and thinking, and we'd say we should be midwives, and here we are.
Yes, and Sarah as well, and Bethany as
Yes,
well.
yeah.
Yes, and so many people. And I saw one of my old AWHONN friends last week. We were roommates at the national conference, and you know me, I was like, so have you thought about becoming a midwife? And every time we would talk to somebody, and I'd be like, oh, you should be a midwife. Becca was like, there she goes again. She started the same old speech. I want everybody to be a midwife.
Yeah. What is the AWHONN conference for?
AWHONN is the Association of Women's Health Obstetrics and Neonatal Nursing. So it's the professional organization that kind of helps to set standards and guidelines, best practices, does advocacy work for, and as far as like, oh gosh, so many things, but they represent nurses in women's health and maternity care. So NICU nurses, labor and delivery nurses, postpartum nurses, women's health nurses, lactation nurses, childbirth educator nurses, all of the nursing in there.
Yeah. Fetal monitoring.
Yes.
There's a lot.
Yes. And now they're having labor support workshops, Sally.
Yeah. Oh, the dream. Oh, yes. That's so wonderful. I'm so happy.
Yes. Me too.
That's great. Great stuff. Great.
Yeah. And I was reading, because I wasn't very familiar with the AWHONN, but your position statement, you said that you were part of the creation of that. Continuous labor support for every woman.
Yes. Yeah, that was one of the things I got to do. So Sally and I, when we were working together, one of the things we did, in addition to starting the natural childbirth series at our hospital, she and I also started a labor support education program for the nurses there, which was really fun. Is it still happening?
Still going, yeah.
Oh, that's wonderful.
Yeah,
because most of us in nursing school don't learn anything about labor support and the importance of it, the evidence behind it, or how to do it. And so we started teaching our nurses. And then I started presenting on it at the national conferences and at state conferences around the country and local conferences as well. Now, like the last few years, they've been offering it, I think, kind of routinely in workshops at the national conference for people who want to sign up to take it. And a lot more hospitals are doing it. I know we didn't invent the idea. I'm sure other places thought of it just as we did. But I got to help write the national position statement on continuous labor support for every woman. There were 3 of us, my friends Kathy Rule and Nancy Travis, and I wrote that together, which was really, really fun.
Wonderful.
And is that for patients mainly, or is it for the nurses as well?
Well, it's that the nurses need to make sure that the patients are receiving continuous labor support. And if
Gotcha.
staffing allows, then the nurse is in a prime position to do it and should have education and support from her or their institution on how to do that. But it also integrates the use of other people that the birthing person chooses. So, if that is a doula, doulas are excellent providers of labor support, or the nurse teaching the family and the partner how to provide that. But it's not so much nurse centered as it is patient centered. The birthing person deserves to have continuous labor support, and the onus is on the nurse to ensure that it is happening, whether it is happening directly by us, we are teaching somebody, or we are honoring the choice that they've made and who they've brought with them to provide that support.
And women who have continuous support look back at their birth as usually a very positive experience rather than a traumatic, scary one.
100%, even if it doesn't go the way that they planned.
Yeah.
That's the evidence is so interesting. Birthing people, women repeatedly report that they have better birth experiences. They're less likely to have an experience that is traumatic or to experience postpartum depression when they are listened to and engaged with during the births, when they have high levels of autonomy, even if things don't go the way that they'd originally thought that they would. They don't care as much about what their path brings as they do about how they are treated on their path.
And when you think of it, isn't that what we all want? We want respect and autonomy and joy during a time like a birth, rather than being looked down on, like you were afraid you were going to be looked down on when you come in. It's like, how can women treat women like that? So we have to, get together and get stronger as a voice for women. And that's really what this podcast is about, that we can find what's important to us floating in our mind and in our work.
Yeah.
And
my bleeding truth was 1800 cc's at home.
Wow. There you go.
That's some bleeding truth, Paris.
Yeah, that's almost a 2-liter bottle of soda. That was my bleeding truth.
Oh my gosh.
Very humbling.
And I think it's wild. Our last episode, we specifically talked about home birth versus hospital birth.
Yeah.
And part of what Sally had mentioned last time is that sometimes women coming to the hospital don't know that they now have a voice to have the birth the way they want it. And that's why, hospital birth sounds like the better option, even if there's those risks like the hemorrhage as well. So what is your opinion when it comes to that? You think it has gotten better, like for going into the hospital?
With home birth? Well, so I think that depends a lot on where you're at. So some communities, for example, in Washington State, they have a smooth transitions program, and midwifery is very well integrated into the health system. So, for example, community midwives who attend birth in freestanding birth centers and in their clients' homes have simulations. They do drills with the emergency medical systems transport teams. They do drills with hospital providers.
Oh, I wish we could do that. We must.
Well, we could. Let me know if you want me to give you resources. We're working on that in this state.
Yes,
but in that state, home birth for low risk people is as safe as it is for people in the hospital. And it's not because home birth is inherently risky or not risky. What makes it safe is having good integration, right? There's lots of studies that show that freestanding birth center birth is as safe as hospital birth when it's done according to, the AABC standards, American Association of Birth Center Standards. And in addition to having similar levels of mortality for both moms and babies, they also have better outcomes in terms of cesarean section and in terms of breastfeeding, lower cost, certainly. But again, we don't have as much consistent data on planned home birth because it really varies so much from one state and one community to the next. So a lot of states, including California, have maternity care deserts. So we have 9 counties in California that have no obstetric provider, and a home birth in a county where, number one, there's nobody there to take care of the baby and the mom, to begin with. And so the midwife is having to travel a great distance to get to that person and to their family. And number two, if an emergency arises, it's going to be a good 2-hour drive to get them to a facility. As you can imagine, that is not ideal. But it's also not ideal to live 2 hours from the nearest maternity services. Mm-hmm. So I think that the real issue is not whether or not home birth is safe. The real issue is we do not have enough healthcare providers, and we do not have a well-integrated healthcare system. So we need to work on how better to integrate and to reallocate. I remember when I lived in Ventura, we had a whole lot of healthcare providers, but they all kind of, they were, you could either have this kind of healthcare provider or you could have this healthcare provider. And the two different types did not mesh well together. Whereas if you went a couple of hours away, you'd have to go quite a distance to get access to care. And so we need to reallocate and redistribute rather than being competitive. I think we need to do a better job of, let's all huddle together and decide how best are we going to tackle access to birth care throughout our state. And then everybody do the best that they can and get the systems to work together. One of the things 2 years ago in 2020, during the height of the pandemic and our racial justice uprisings, the California Nurse-Midwives Association partnered with a coalition, including Black Women for Wellness Action Project, and we were able to pass the SB Senate Bill 1237, the Equity and Justice in Childbirth Act. I'm sure I'm saying it wrong. I have to look it up. But anyway, this bill was designed to help untether midwives from the physicians who are already clustered in communities so that midwives could go to underserved areas in the state that needed these resources. And so we're still working on implementation of that. One of the challenges is that midwives in most hospitals can't get privileges unless a doctor kind of endorses them and says they should. Most hospitals have bylaws saying that the physician has to supervise the midwife, even though the law doesn't say that anymore. So when we're looking at these maternity care deserts that have critical access hospitals, I would love for us to get midwives privileged at those facilities so that we can be bringing the midwives to where the people live and get them the care that they want and that they need, and maybe, partner with family practice doctors or general surgeons, whoever is already at that hospital, so that if our patient does need a cesarean on the fly, they can get it, and so that they can be getting good prenatal care and screening, so that if we know that they're going to need to be in a higher level of care, we can get them to the tertiary care centers that are a couple of hours away well in advance before they have their crisis.
And that would be a great opportunity for new midwives as well. If we could have an experienced midwife and then some new grads to come and work with them. Yes.
And it would also be a great way for us to partner with our CPMs, our certified professional midwives. In California, we call them licensed midwives. In a lot of these communities, there are CPMs there who are willing to provide home birth or birth center birth, and the nurse midwives, because we can have hospital privileges, if the doctors say okay, we could be partnering with them and bridging these gaps.
Oh, that would be perfect. Yeah, if she did need to be transitioned to the hospital, she could still go to a midwife.
And that could be happening in cities in California like Ventura. That could be happening now. So Sally, if the hospital decided to update their bylaws, women birthing in freestanding birth centers like Grow or Sunrise or the Ventura Birth Center, or women who are having home births, the most common reason for a woman to transfer into a hospital is either because she wants pain relief or because her labor isn't progressing. So Pitocin or an epidural, and those are both within your independent scope of practice according to California law. So hospitals that's one of the things I hope that they will do to better integrate and improve the safety of birth for people. They can better integrate midwifery care by allowing community midwives to transfer to hospital midwives when those things need to happen, so that the patient continues to get really trauma-informed, person-centered, gentle care.
I must look into that and see.
I can help you.
Yes, please.
Yeah, the Purchasers Business Group on Health, we have a community transfer project going on right
Yeah,
now. And both the
Fantastic.
California Association of Licensed Midwives and the California Nurse-Midwives Association are participating, and there's some great tools. Ooh, I can give them to you to put on your website.
Yeah, please
That's what
do.
I
That would be
really
great.
enjoy about you, Paris. Like I'm looking at this one woman and her labor and how it can, give her the birth of her dreams. But you're kind of looking at this global whole scene of all of the women and how can we make it better for all of them? And
Yeah.
Mhm.
it's really
And just recognize that
expansive. I love that.
it's different for different, locations. We're in
Yeah,
California, and Ventura is really lucky with a lot of their resources.
Yeah.
But,
yeah,
you don't think about the other aspects of
yeah,
California that might
right.
not,
Yeah.
let alone other
Yeah.
states. So, yeah,
Yeah. Isn't it
I like that you.
interesting? I feel
Yes,
like I feel like my background as a dancer is really helpful here because I tend to see things like in choreographic, like in my mind, I see all these pieces moving and,
yes.
um,
That's so
like,
great.
that's silly.
That's so good.
Yeah.
No,
Yeah.
that's great.
Actually,
Yeah.
I just had a vision of you doing your belly dancing with the swords. Yes,
Uh-huh.
you're going to cut through that red tape.
Uh-huh. Bureaucracy be damned.
Where there's a will, there's a way.
Yeah.
Aw.
Yes.
Yeah. But
Wow.
Paris, you're enjoying your job right now, and
I love it.
yeah, that's so great. Um,
Yes.
and of course, we want you to continue doing your job, but we also want you to keep going on your path of, you know, policies. You were always looking at the policies. How could we make that policy better? But now it's a bigger policy all around that you're looking at, right? And
Yeah.
you're destined, of course, to be in politics, I feel.
Oh,
And
I know.
I
You've been telling me that for
I
such a long time.
support you in every way.
I want
I
to
want
keep
to help
catching
you.
babies.
Yes. But you somehow are able to do both. It's like you have the two roads going at the same time, I feel.
Yeah. You know what's
Yeah.
interesting? One of the things I've been learning is that our legislators, I mean, they do good work, right? But when we are engaging with members of the legislature, we engage with their staff who we don't vote for.
Mm-hmm.
And it's the staff who are really taking
Mm,
our feedback
yeah,
back to their bosses, to the legislators.
That's an
Maybe,
interesting way to view it. Yeah.
yeah, I feel like I'm able to get a lot of work done in this capacity. Maybe someday I
right.
will be in a
Yes.
political office. I don't know, but I do love that I'm able to marry advocacy and direct patient care.
Yeah.
Yeah,
Yeah.
absolutely. And I know last week we had the news from the Supreme Court over the overturn of Roe versus Wade. I don't know like how you feel about talking about it, but if you are comfortable
Yeah,
sharing your
no,
take on that
yes.
situation.
I am very fortunate in that I mean, I have a lot of privilege in my role that I can be outspoken. Well, we'll start with this. The California Nurse-Midwives Association is on the steering committee for the California Future of Abortion Council.
Mm-hmm.
So we've been working really closely with the governor and the legislature to help with policy around making abortion safe and accessible and affordable in California. We have 13 bills that are moving through the legislature right now. One of them has already been signed by the governor, which is great, all around abortion access and safety. In addition to that, SCA 10, there's a constitutional amendment that has made it through the legislature that will solidify the right to termination care and abortion in our Constitution. So it's made it all the way through the legislature, and in November, it's going to be on our ballot. And I'm hoping that all of your listeners will decide to take their mail in ballot that comes to every one of us, fill it out,
Mm-hmm.
and vote for us to adopt that amendment into our Constitution.
Wow.
Now, so that's where I am policy wise. As far as my own personal practice, I've been a midwife for 4 years, which is such a short time. It's crazy. Um, And during that time, I've been very fortunate in that I can provide full scope midwifery care, including abortion care. I work in an office that is very pro choice, pro person. I want to say pro woman, but that language is changing, right? Because not everybody
Yeah.
who has the
Uh-huh.
capacity to become pregnant identifies as a woman. And so that was one of the things early on. At this point, for as long as I've been there, I've been the only midwife providing abortion services, and I don't think that is going to stay that way. I think it's been that way for a while. I was the only one interested, but as our staffing mix has changed a little bit, I know that other midwives are interested too. But during the pandemic, we've been so short staffed that everybody has just been doing what they can do the most efficiently. So the midwives have been doing all of the maternity care the last 2 years, and our physicians have been doing as much of the GYN care that they can. But we're going to be offering an abortion training on November 6th in San Luis Obispo for midwives, nurses, nurse practitioners, anybody who wants just to learn more, even if they're not going to do it themselves. We're going to be really focusing on making abortion accessible and easy. So we're expecting about a 3,000% influx in our in demand in the state for abortion.
People
Wow.
coming from other states.
Yes,
Oh,
yes,
okay, that makes sense.
yeah.
Yeah.
So we're thinking about how we can make it easy for them so that they don't necessarily have to pay for a plane ticket on top of services. And certainly there are abortion funds, and there are a lot of pieces there as well. But we're going to be focusing on medication abortion, on telehealth abortion. And telehealth gets super tricky because when you're crossing state lines via the internet or the phone, there's concern about providers being prosecuted
Oh,
for
wow.
violating the laws in other states. And so legislatively, some of the bills that we're working on in California that the FAB Council is working on address that. But just because our state law says something doesn't mean another state won't say, well, we don't care, you're breaking our law, right? And there are concerns certainly about extradition, about being taken from this state to another state where they can prosecute you and hold you incarcerally.
Wow.
So there's a lot there, but we knew this was coming, right?
Yeah.
Um, my hope is that this will force the hand of our Congress at the federal level to finally do some work of legislating and stop fighting amongst themselves and leaving it to the courts to decide what is and is not legal, because that's not what the courts are supposed to do. The courts are supposed to
Mm-hmm.
be they're supposed to be interpreting the law, not making law. So Roe was never really solid. The legislature never did its
Mm-hmm.
job of creating legal statutes there. And I'm hoping that
Gotcha.
Yeah.
there's enough energy and momentum, given that the majority of Americans do support a woman or pregnancy capable person's right to choose. And then we can get back to other issues such as making it accessible, not just legal, you know,
Mm-hmm.
getting back to
Yeah.
the
Yeah.
whole reproductive justice piece where we're making sure that people have safe communities to raise the children that they choose to have and that they can do so with
Exactly.
dignity. Yeah.
Yes. Yeah.
Yeah.
I've been thinking a lot about it, and I really want to help focus as well on educating the young girls in and young boys in high schools about their own fertility and forms of contraception that are available to them. Because there's a big hole there as well, isn't there? Um,
Yes.
yeah, I
Yeah.
remember at home in Ireland, we'd sit in our little school uniforms and the nuns would never want to talk about sex. Like sex was like a big taboo, like why would you ever want to even think about it? But of course then there was some girls who were somehow they were able to get on the pill and we were all like, how did you get the pill and where did you get that?
Yeah.
And but now I have some really young patients, and they come in with their really progressive moms, and the mom's like, I want her to talk to you, and you tell her about all of the different forms of contraception. I want her to pick one herself, and I look at the mom and I'm like, I love you. I think you're fabulous. And I wish
Yeah.
all moms would, do that for their kids, And then I look at the
Yeah.
girl and she's like, well, I want to talk about Nexplanon, or I want to talk about the IUD. And then I hear all of these like rumors that even that the Supreme Court would try to,
Mhm.
outlaw. It's
Do
like,
you think there's a risk of that getting to that point of
yeah, do you think,
certain?
Paris, it's going to just keep going and going?
I'm really
Can
worried that
we?
I'm going to have to be in one of those red dresses with the bonnets pretty soon, a la Handmaid's
From
Tale.
Handmaid's Tale?
I'm
Yeah.
glad
Horrifying.
I won't, because I'm infertile now.
I know, hooray for perimenopause is here. Sally, when is my period going to finally stop altogether? I don't. So at this point, what the Supreme Court is saying that the court will not uphold a person's right, that this is not in the Constitution as they interpret it. So they're saying the states will decide. They certainly do not have the authority to make abortion illegal. They don't have the right to legislate whether or not abortion should be made illegal across the board. They're saying that that is up to each state. They are not recognizing that the right to privacy, as was argued in Roe, includes the right to an abortion, and that it is our constitutional protection there. I don't think that they will make it, so they already have in terms of the Affordable Care Act. I believe it was 2010 with President Obama, mandated that insurance companies pay for contraception, at least one of every type, right? And then, as we know, Hobby Lobby took that to the Supreme Court, and the Supreme Court found in favor of Hobby Lobby if their faith, Catholicism, for example, uh, dictates that women shouldn't use contraception, and the owners of a company, are of that faith, then they have the right not to provide contraceptive coverage in their insurance plans.
Oh,
So
wow.
that's already been done. That precedent has already been established
Right.
based on
Yeah.
faith, which
Yeah.
unfortunately we live in a country that doesn't have a nationally provided health system.
Mm-hmm.
Our country, based on capitalism, dictates that your employer is supposed to provide your health insurance, but because employers are considered people who have the right to freedom of religion and free speech, if their religion dictates that contraception is immoral and that it's outside of their faith, then they don't have to provide that to women anymore, which means that insurance no longer, in all cases, would have to provide contraception care.
Wow.
Wow. Amazing, huh?
And I think that kind of happened without us really paying much attention to it,
Yeah.
especially
Mm-hmm.
um, in
Yeah.
places where we have a lot of privilege.
I can't personally see it becoming anywhere that's a law that, right, as you were saying, that you can't have contraceptive care, but it is kind of sneaking in different ways
Mm-hmm.
of like insurance as well. But I am concerned more of just the ramifications now of being up to the states
Mm-hmm.
for just abortion on its own, and how
Mm-hmm.
there's a lot of maybe misinformation or just not fully understanding of why abortion is a good thing to have as a choice. Not that it is something to be pressured into
Mm-hmm.
having.
I think it's
Well,
wording as well. I think if you hear the same wording over and over again, you start to like think, oh, that's true. It becomes true.
mm-hmm.
Like being the hypnotherapist in the group, I know how strong the words can have the effect on your
Yeah.
emotions
Mm-hmm.
as well as your thinking.
Yeah, so
So I
it's
think
really
that's.
interesting. If you look at the states that have the trigger laws in place, or the states that are really poised to make abortion more difficult to access or even unlawful in all cases or most cases, if you look at a map of the United States and you map out which states have the most restrictive abortion laws, you will see that those states are the same states that have the most restrictive laws with regard to midwifery practice. And if you look at a map a same map and you look at infant and maternal and fetal mortality rates, you'll see that those same states have the highest rates of maternal death. Right. You'll also see that those are the same states that have the highest concentrations of Black, Indigenous, immigrant, other people of color. You'll also see that those are the states that have the highest rates of poverty and the widest wealth gaps. And it really doesn't have anything to do with choosing life. It has to do with maintaining the status quo with white supremacy and poverty and the patriarchy so that people remain disempowered. The way I see it is that faith is being wielded as a weapon to keep people disempowered. And I gave a talk at AWHONN last week, actually it was this week, on just this thing, a historical through line that goes through and explores indigeneity, through 1619, through the Civil War, through Jim Crow apartheid to now. And it shows the way that the system was designed to result in the maternal mortality crisis and the racial disparities that we have today. Abortion restrictions are just part of that. They're not by themselves. They are part of this larger system.
Exactly. And it's like, if you can address those other issues, then the need for abortions is going to go down significantly because it's going to be more habitable and welcoming and even just affordable to have kids in those areas.
Yeah, if people have guaranteed health care, if people have enough food, if they're not living in impoverished communities, if they have access to good schools for their children, if they're not being policed in their own communities, we could really change the soil that we are growing our garden in.
Yeah, that sounds very pro-life to me, Paris.
I agree. I am very pro-life and I am very pro-choice at the same time.
Me too. I was listening to a man on the TV recently, and he was saying how he was pro-life, but he was just focusing on this abortion issue, but he was also pro-death penalty.
Oh gosh.
So it was
because it's not at all about the life or the well-being of the person. It's about white supremacy and the patriarchy, that integration of those two things. And if you look at who is on death row, that becomes quite apparent. And if you look at also the rate of incarceration in this country, we have the highest rate of female incarceration in the world in this country. And most women who are incarcerated aren't violent offenders. Most of them are either incarcerated for drugs or for sex work. They've got an extremely high rate. The vast majority of those women have suffered abuse themselves. So we've got a system that is working really well to do exactly what it was designed to do.
Wow.
Yeah.
Paris, I'd like you to talk a little bit about the disparities against women of colour in maternal child health and even in midwifery.
Yes. So the statistics vary from state to state and community to community, but nationally, Black women are 3 to 4 times more likely to die in pregnancy, childbirth, postpartum than white women. Native American women who are on the reservation have a higher rate of maternal mortality. When they are in our communities, it's a little bit less than that of Black women. And that's not because they're treated well in our communities. It's because there are such high levels of poverty on the reservation. Now, it's interesting. There have been studies. I think a lot of times people think that when Black women are dying at higher rates than white women, the assumption is, oh, well, they've got these bad diets, they've got these bad lifestyles. We tend to blame the victim. But the studies have actually shown that when Black women immigrate here, first generation Black women, their mortality rates are the same as white women's. But their daughters who are raised in this racist space, that's when we see those mortality rates increase. And I know, right?
So sad.
Yes. And there is something called weathering, where we see bodies experiencing trauma, racism, abuse repeatedly over time, and the way that it weathers or damages their cells, their bodies, their blood pressure goes up. Um, Now, the March of Dimes has called upon our health system to increase access to midwifery care. Midwifery is seen as a tool to address racial disparities, and that was part of the reason that we passed SB 1237, was so that we could use it in California to get midwives to Black and Indigenous and Latinx and immigrant other people of color. And one of the challenges we have, though, with midwifery currently in California, about 90% of our midwifery workforce is white, and we know that there are significant benefits to having racially concordant care. And race is a social construct, we know that, but the experience of racism is very real. And so having people who have similar lived experience is really helpful. It's one of the challenges we have as midwives in California, is to really do a better job of recruiting, supporting, mentoring people of color into and within our profession, so that they have greater capacity. But I mean, even nurse midwifery is not immune to that sort of racism. You know, when people of color are interviewed and surveyed about their experiences within this profession and lateral violence, the way that they're treated within the system. That's a very real thing. And also, it's important to note there are two types of midwives in California. Again, CPMs or LMs and CNMs. And historically, midwifery was criminalized shortly after the Civil War, during Jim Crow apartheid, and through the early 20th century. Now, midwifery started to make a comeback in the 1920s with Frontier Nursing Service and Mary Breckinridge, where we went to school.
Yeah.
But unfortunately, she was the granddaughter of
so awful.
She was, I know, she held very racist and eugenicist views. Her midwifery workforce in Kentucky wouldn't provide care to Black families and would not allow Black nurses to train. And that continued. So it wasn't until after Mary Breckinridge's death that that system allowed Black people to be trained as midwives through that system. And similarly, the American College of Nurse Midwives, same thing. They wouldn't let Black people into the association until during the Civil Rights Movement. And I'm glad that they've made that change. And actually, last year they came out with a Truth and Reconciliation resolution, which was really powerful. And our school, Sally and I both graduated from Frontier, released a similar statement as well. But the damage has certainly been done. And so most midwives now are white. In the United States, I believe it's about 95%. And similarly, our associations have pushed down other types of midwives, so CPMs throughout the country. Our organization has actively pushed to keep them from having authority to practice in states. So, we're not pure and clean. We have a lot of reparative work to do as well. In our state, I'm really hoping that we can do a better job with our CPM colleagues of repairing bridges. And I would love to see us all practicing under a midwifery board. Currently, they practice under the medical board. We practice under the nursing board. It'd be great for us to be working together. And, similarly to how there are different types of nurses, there are ADNs and BSNs and MSNs, and you can get various certifications, RNC and different things. It'd be great if we had midwives and there were CPMs and CNMs, and you could also, do all those things. So that's part of what I am envisioning and holding in my heart and mind.
If you're a lady of color, or if you're a person of color listening to this and maybe having aspiring thoughts that you'd like to be a midwife, please come and join us. We would love it.
Yes.
We need you.
Yes. I think, Sally, there's contact information on the website for this podcast. You can absolutely reach out to Sally.
Yes.
And I don't know if my contact information will be on there or not, but Sally knows how to.
Yes.
Okay, yeah, Sally knows how to get a hold of me for sure, and I'm happy to help with connecting you to resources, to mentoring, to talking with you myself, to helping myself. That's one of my passions.
And maybe not to think that Frontier would not be a good choice now.
No, they're doing a lot better. They're doing a lot better.
Really trying. Yes. Yeah.
And I wouldn't say they're just trying. Yeah, they're not just trying. They're doing a lot better. They have been doing a lot of really important work. And in fact, one of my professors there, Dr. Heather Clark, is now the president of the American College of Nurse-Midwives. She's the first Black president of ACNM ever. And she was professor at Frontier. I know. So this is the past that we need to acknowledge. We are not defined by the worst thing we've ever done, but it's important that we acknowledge it so that we can learn from it and do a better job.
Mm-hmm. Right. Exactly.
Absolutely.
Yeah.
So we'll definitely add your information, Paris, and any links to contact or ask questions for. But also, if you're listening to this and want to ask more questions for a later podcast, we'll have a link for that down in the description below as well.
That was so wonderful. I could sit here all day listening to you and learning from you. Thank you so much. And perhaps you'll come again. Maybe we'll have another podcast with Paris if she has time some other time.
Yeah.
I would love to.
We would love it too.
And thank you for everything that you're doing in such a well-rounded fashion of women's health care.
Yeah.
I think it's really important that you do understand all the different parts of it and, share it with the world too. So thank you, Paris.
And keep belly dancing in your mind and swirling all the parts, and it'll turn into the most beautiful dance like all your dances.
Yeah.
Absolutely.
Yeah. Here's the choreography.
Yes.
And if you guys are listening to this, please don't forget to like and subscribe. It means the world. And share this podcast to learn more about Paris and these different missions for women's health. And we'll see you in the next one.
Thanks, Paris.
Thanks
a million for being there.
Thanks a million.